Hey, good morning, everyone. Welcome to UroNurse. I'm your host, Vic Senese. Hope it's warm where you guys are at because it's cold by me. I did put something in the comments. Let us know what the temperature looks like by you guys. So let us know. Hey, be sure to like and subscribe to the show. We always appreciate that. Helps our ratings. And today we're joined by Dr. Brent Sharpe, a board certified urologist and nationally recognized leader in minimally invasive and robotic urologic surgery. Dr. Sharpe has a special interest in advanced prostate cancer care, benign prostatic hyperplasia, and cutting-edge surgical techniques that improve outcomes and quality of life for patients. He's known not only for his technical expertise, but also for his patient-centered approach and commitment to education. We're excited to have Dr. Sharpe with us to share his insight and clinical experience. Welcome, Dr. Sharpe. And Lori Atkinson, our other expert, joining us today. Welcome. How you guys doing?
Trying to stay warm and prepare here in the South.
Same here.
And Lori's from pretty close to the same temperature. You probably have 6 below this morning.
Oh, I don't even want to look.
You know, in Chicago, it's just cold. You just put on more clothes, layer up. We're used to it.
Yep.
But you guys down south, you're not used to this stuff. So the trick is layers.
The trick is layers. Learn that being from a farm and having to feed cows in snow weather. You learn how to do that. And to see people just, I mean, I don't think there's been a gallon of milk on the shelves for about 4 days down here.
Yeah. Well, too bad you're not still on that farm. You can just get your own milk, right? Fresh.
Right.
That's right.
All right.
Doesn't get stuck.
Well, Brent, I'm going to switch you over to your slides and take it away.
Awesome. Thank you so much.
Why am I push buttons not working here? Let's see.
All right, everybody. Well, so again, my name is Dr. Brent Sharpe, and this is an extreme passion of mine about how to change and advance the quality of life of patients. So we're just kind of basically a little about prostate cancer and what I'm going to call the NanoKnife difference. Okay. So again, a little bit about me. Just I always think it's important to understand who you're talking to, and especially their biases. You'll hear the word bias several times in my presentation because I think it's very key. So I've basically been blessed to practice in 3 different states, currently in Atlanta with Georgia Urology. We're the world's largest privately owned urology practice. I trained at Emory. As Vic said, I do have an absolute passion for trying to improve the quality of life and minimize the effects of what we do in medicine. I always said my job is to work myself out of a job. I've completed about 100 of these NanoKnife procedures. It's been the fastest to get to that number, and basically lead surgeon for a NanoKnife program here. We really adopted this within Georgia Urology. I'm proud of that. We also serve as a certified training site. And again, as Vic said, my focus are, again, quality of life, preservation, and restoration. So what are we going to cover today? You can't do this talk without just a little bit about prostate cancer overview and where we're at. Mainly, what is focal therapy? Maybe a lot of you not heard that term. We're going to talk about focal. Sometimes in the talk, you'll hear me mention regional. We'll delve in that a little bit. Then what are the types of focal therapy that can be done, thermal versus non-thermal? It's going to be a huge key concept for today. The NanoKnife system, how it basically works, try to put those in some very basic layman terms. So when you have patients or people you want to talk to, you can make it very simple. As we've said, I'm from the South, so South equals simple in my book. How's the NanoKnife different? That's going to be the meat of this. There's a lot of things that are just changing and evolving very quickly, very rapidly. And then who's a candidate? So if you leave anything here today, one of the things I think from a prostate cancer standpoint is a lot of people are candidates that you may not hear about or think about. So really, prostate cancer, basically about 1 in 9 men get prostate cancer. It is the most prevalent male cancer worldwide. I was a little shocked at this number. I had not looked it up in a while. 1.5 million men per year worldwide. That doesn't count the people who are already living with it or undergoing treatment or other side effects of the disease process. So again, this affects a lot of people. That cannot be understated. This is also, prostate cancer is unique as it affects obviously the patient. And while all cancers affect the family nucleus, prostate cancer affects that in a way that most other cancers don't. And that makes it very unique because it affects the man, it affects the wife, the children, the whole family dynamics. And then we cannot lose sight of that. We don't want to cure the disease, but break the man. So SOC, standard of care of prostate cancer. This is not going to be big news for anybody. Radical surgery. basically young, I think as of 1909, did the first prostatectomy. That was open surgery, obviously. Now we've changed how we do open surgery, different techniques, different approaches, but it's still surgery. So then a big change came around in 2010 where we had a lot of people going to robotic surgery. I think it was very rapid, about 5 years. We went from 97% open to 97% robotics. But again, at the end of the day, it is still surgery, still removing the organ. That was an enormous advancement, quality of life, all these things, but it still was at its bare essence surgery. Radiation, we all know about radiation, been around for a long, long time. It can be internal or external. External is your traditional radiation where a person goes to a radiation center. We cannot forget proton beam. While the new guy in the radiation realm is still radiation, the side effects are still those associated with radiation. And again, while we've gotten better at the really major complications associated with radiation, those end user issues that people worry about prostate cancer, erectile dysfunction, urinary incontinence, problems urinating, have not changed a ton with radiation. Again, whole gland therapy. Both of these modalities, standard of care, are going to treat the entire prostate in one setting. We'll call whole gland therapy. So they're going to come with what I call whole gland side effects. Mainly those are urinary, right? Frequency, urgency, having to go to the bathroom all of a sudden, having to go a lot, not being able to get to the bathroom on time. Hallmarks of radiation. Urinary retention. Again, this is going to be a concept to also talk about. Again, the side effects of urinary retention needing further procedure is going to be prevalent in every modality except what we're going to talk about today. Urinary incontinence, this is the leakage of urine, uncontrolled, typically stress with surgery, cough, sneeze, go out and do activity. With radiation, it's typically more that frequency, urgency, overactive bladder, urgent incontinence, but there's still a component of leaking urine, which has many manifestations we'll touch on. Erectile dysfunction, again, you cannot underestimate what this means in the scheme of compliance with drugs, compliance with other treatments, compliance with your prostate cancer treatment, the aversion of treatment. So we can't overlook that, and the need for other procedures that are associated with these whole gland standard of care options. While they're great, cancer deaths are down, quality of life is up, all these with advancement that we come in technology, but we're still treating the whole gland, and those urinary and erectile dysfunction issues still persist and plague us today. So that leads us to what is the rationale behind focal therapy? Well, first and foremost, it's targeted disease eradication. We don't want to kill the man by treating a small disease and small organ. And again, obviously, metaphorically speaking, all cancers essentially have a focal option. I use this all the time. In 1980, my grandmother's entire breast was removed. We did mastectomy for every breast cancer. That is not even close to being the most common procedure we do for radiation. Same thing happened with kidney in urology. Same thing happened with pancreas in general surgery. So all of the cancers have this option. Why don't we have it? Been doing surgery since 1909 for prostate cancer, and we still haven't come up with a focal option that is viable, works well, and I hope to disprove that statement today. We want to minimize side effects. Again, we don't want to kill the whole dynamics of the man or traumatize the man in such a way from a disease we know a lot of men don't die from. You have to understand the following fact. Men who undergo treatment for prostate cancer live with that treatment and the side effects of that treatment longer than any other cancer. Any other cancer, pancreas, brain, LAs, they live with the treatment longer. So we need to get into a realm of minimizing that side effect at every turn we can. Focal therapy options, mainly two main categories, thermal and non-thermal. So the thermal ablations are typically the high intensity focused ultrasound. This has been around probably 15, 20 years. It has struggled from time to time to find its niche. It's coming back in the focal realm, but still has inherent problems. Cryotherapy, that's freezing. Again, when you freeze something, there's going to be inherent options there we'll talk about. Focal radiation is a new concept. This is where those internal seeds, either low dose or high dose, can be placed in a certain area to kill a cancer without the whole gland being treated. Does minimize side effects, but it still has radiation. Laser, obviously, we know what those are. And then the final new one is called irreversible electroporation, or what I'm going to term NanoKnife or IRE throughout this talk. And this is completely different and revolutionizing where we're at. So thermal injury. So basically it's a thermal burn of some type. It's either hot or cold, destroys the cells. The non-thermal injury is electrical energy. So we're going to induce cell death without giving a thermal burn, and that preserves structure and minimizes scarring, which again can't be overstated. So what is NanoKnife? Again, we talked about use electrical energy to deliver through small pore, to induce small pores in the cells via these probes that are placed in the prostate. This is an outpatient procedure. There is no incision. So here's a slide that depicts how this is done. So the bottom right-hand picture is what you would see in the operating room. This is a transrectal ultrasound placed inside the rectum. Obviously, the pink organ there is the prostate, and then these needles or probes are going into the prostate. The right-hand picture depicts a lot, okay? Number one, we see the probes placed around the lesion. This is unique. In this picture, we're going to talk about in a minute, we are going to box in this cancer before we ever initiate any energy. So we're going to treat outside in. Therefore, all the side effects are going to be controlled at the beginning of the procedure, and the safety mechanisms are going to be set up the treatment, then deliver the energy, not deliver the energy and turn it off when you think you've treated enough. This is a huge contrast that can't be overstated. So here's just a picture electron microscope showing exactly what this does. At 5.5 milliseconds, you see little cell wall changes, and then you see these holes created in the cell. By creating the holes in the cell, we all know that cells like a equilibrium. They don't like things coming in and going out that they're not allowed. And by opening those doors and windows to the cell, that's what induces the cell death and then causes the tumor to die without causing the scarring process. Versatility with NanoKnife. Extremely versatile. And I tend to learn, even after doing 100 cases, learn every day of somebody I can apply this technology to. So this is 3 depictions. We've got a tumor. We've isolated that tumor, the blue field being the treatment field. And you can see the small circle bottom right of that treatment there. I don't know if they could see the cursor or not, but down here, that's the nerve bundle. So we're preserving that. Here's another example where we're treating a whole side. So this guy has more than one lesion, more than one area that needs to be treated. We're able to do that. And then the final is just basically opening that door to how we can apply this technology to cover a different area. So a real popular toy right now is those magnetic tiles. So imagine if you had all the triangles in the magnetic tiles and you had your prostate, you simply are going to stack triangles in a way to cover an area to treat the cancer. And you can define that area at the beginning of treatment. So what are its advantages of the NanoKnife for IRE? Number one, first and foremost, everything revolves around preserving cellular architecture. Okay. In order to if you maintain the cellular structure, the environment around it, the support, don't cause the scarring, then you protect the surrounding structures. As I've shown here in the previous slide, we can treat larger areas. Okay. We can treat larger areas without increasing side effects. We all know that in surgery, the more you do, the more likely you increase side effects, the more likely you increase complications, and the more things you compromise. That is not true with this procedure. So we now data to support treating a larger area, getting a better margin, getting more tissue treated so we decrease recurrence rates in our infield treatment area. We don't increase the side effects, and mainly those 2 side effects, we're going to focus on the urinary symptoms, i.e. urinary incontinence and erectile dysfunction. We don't need an MRI lesion. A lot of people think focal therapy, I've got to see the cancer on an image that I can target. That's absolutely false. We can target a regional area, as we've shown before in the previous slide, and we can do that very effectively and know that treatment area and define that treatment area and the margin before we ever hit the energy button and begin to destroy the cells. This all leads to protection of quality of life. Again, patients don't want to die of cancer. There's no question about that. But they don't want to have a miserable quality of life from that treatment of any disease process. This protects their quality of life for both them, their family, and especially their spouse. Maintains future treatment options. I think of all this in healthcare, we know inherently once you do something, option B or C or D is going to be A, more difficult, and you're going to increase the complication rate because you've already had a procedure. Again, faults in this. There's a ablate and resect data. They ablated the tumor, then they resected the tumor. The ability to resect the tumor by standard radical prostatectomy was not altered at all because they'd had the NanoKnife before. So we then also maintain treatment options in the future because we don't damage that cellular structure. So having other options is always there if needed. You can repeat it. You can't. There's a limitation to radiation. I mean, how much you can get, you can't repeat it. You got a limiting factor there. You don't have that with cryotherapy. As you're freezing that ball, you've got a limitation. You cannot get so far in an area. You're going to damage other structures. With NanoKnife, we're going to build that fence around it. We're going to know that area before we ever turn the energy on, so we can be better. You got lower complication rates if additionally treated. Again, this is the concept that when you do second procedure, complication rates goes up. Well, because we don't mess up on the first one, the second one doesn't increase the complication rates either. Key differences, and this is just a summary again. This is outside in technique. Cryotherapy, high intensity focused ultrasound, radiation, all those set up a device, a energy source in the middle of that tumor and disperse it outward. Therefore, you have to depend on the surgeon to turn the energy off so that he does not damage structure. As you saw in that slide, as we're putting those probes around the tumor, we are defining our treatment area. We are protecting the adjacent structures before any amount of energy is ever delivered. There's no limitations on size, calcifications, and location of tumor. All other modalities have some form of limitation. For example, cryotherapy or seeds, you cannot do it on large prostate. If you've been in the healthcare for a while, you know, man with big prostate, they get medicines, it shrinks the prostate. Now they can have the seeds. It makes them a candidate. We don't have to worry about that. I've treated up to 181 gram prostate with NanoKnife so far. High intensity focused ultrasound, or HIFU, they can't reach the anterior lesions very well. These probes are bigger. They don't bend as well. So they can't get underneath that pubic bone, and you can't have calcifications. Tuesday, I did a biopsy, and even the biopsy needle, the MRI guided biopsy needle, I had to advance it past the calcifications on the capsule before I could even just get the biopsy needle to go through. So calcifications is a contraindication. And we know probably 30, maybe as much as 50% of men may have significant calcifications associated with their cancer in their prostate. So you're taking about 30 to 50% of people off the docket for focal therapy for high intensity focused ultrasound in the beginning. Take this one home. Does not lower urinary tract symptoms. Every other modality of prostate cancer treatment, radiation, cryotherapy, high intensity focused ultrasound, lasers, are going to worsen the lower urinary tract symptoms. Frequency, urgency, we talked about, urinary retention, urge incontinence. NanoKnife does not do that. Outside the small incidence of urinary incontinence, which is less than 1%, surgery, radiation are probably 5 to 15%. So we've multifold decreased that. We do not cause any problems with lower urinary tract and symptoms, and we may actually make it better. I'm going to talk about that also. We talked about the retreatable, but most important, we don't burn bridges. When you do your first therapy, you never want to make your second operation worse. With all other modalities, especially those with thermal injury, you do. And how do I explain that? That's the grilled, frozen, and shocked analogy. So again, if I take my hand and put it on a grill, or if I take my hand and put it in the freezer, I will get my hand back, but it will not look, nor act, or function like my hand. If I was to take my hand and stick it where my computer's plugged in the outlet, sure, I would get shocked. But as soon as I pull my hand out, my hand is going to look, act, and most importantly, function like my hand. So we're not destroying. That's the best analogy I can give you. Imagine that really nice tasting steak. It did not look the same once you put it on the grill or put it in the freezer. But if you were to plug it into your outlet, that steak would still look the same. So that's it's key to keep in mind. Who's a candidate? I said we'd touch on this a good bit. So classifications, low, intermediate, high. We probably all know those. We know Gleason score. The new term is the grade group. Within intermediate risk, you have favorable and unfavorable. So those are the classifications. Right now, and in the beginning, we're living in this low and intermediate risk prostate cancer patients. Again, I talked about, at first doing a few of these cases, I was in this box, need to be intermediate, need to be favorable, need to be lesion based, need to be in a small area. I took the box and basically ripped it up and threw it away and said, okay, I'm done with that. I tell people sometimes I don't work outside the box or think outside the box. I live in about 3 states over. So this is the indications, but once you know technology and you know a tool, you can apply it in many different ways. Radiation, high intensity focused ultrasound, failure. So this salvage NanoKnife concept. And in this setting, your high risk patients can be treated. I have done that, Gleason 9 and a recurrence after radiation, very successfully treated with the NanoKnife in the salvage setting, not the initial thing. Like I said, if you take another point home, please, it is that many more men are candidates for this procedure than anybody will admit to or realize. I've talked about initial and current. I have a whole series of unfavorable risk prostate cancer patients that have been treated successfully. I recently heard a podcast where they said that these were not candidates and barely could not reach through the screen and scream at them, but that doesn't allow you. I have treated a 47-year-old with 4+3 and 5 cores on one side. That is what most people would term early age, likely to fail, unfavorable risk pathology, all treated successfully and proven biopsy after NanoKnife to be successful. We easily do the half a gland. I'm probably 40–50% of my patients are about a half a gland. And that is because, again, we get a better margin. We don't sacrifice side effects. You can treat both sides in sequence. So again, we don't do whole gland therapy in one setting, but I do have a small series already where we're actually treating both sides. And just saw a guy from California by virtual visit, and that was his choice. Again, unfavorable intermediate risk disease, all day long, all month long, we treat this and have been very, very effective. And again, proving that we are treating these patients in unfavorable intermediate risk by post-biopsy. So again, kind of coming to the end here, after 100 men, it's hard for me not to say it's my first choice. I try to begin to, when I started looking at men and who I could get into this therapy to get all the benefits of it. And now that is completely flipped, and I'm saying, why can I not do this procedure? I know it doesn't cause scarring. I know it doesn't increase side effects. I know it gives them a better outcome. It has cure rates on par with radiation and surgery. Why would I not be looking at how to get this guy into that, what I would say off the top of my head, Mercedes choice or Mercedes-Benz choice? Everybody wants a one and done. Nobody likes going to radiation for 20 treatments, 40 treatments, whatever it may be. This is a one and done. It lessens that active surveillance burden. This is actually where I'm growing my practice in applying this. A lot of men went on active surveillance. Why did we come up with active surveillance? It's because we didn't want these guys to have these horrible whole gland side effects from a cancer they weren't going to die. But they still live with the ramifications of watching a cancer. It has psychological cost. It has physical cost in other procedures. It has risk in those procedures. And if we can do this treatment without causing major complications like the whole gland therapies do, we can get people off active surveillance, a one and done, and they don't have to go through these years of biopsy. Remember, active surveillance is biopsy in a year, if that's okay, biopsy in 2 to 3 years, and then maybe biopsy in 3 to 5 years. They're having to go through multiple biopsies. And even though it only has a 1% complication rate, biopsies do lead to infections. Less cost, direct and indirect. And you see the asterisks there. Direct cost. It is simply cheaper to do NanoKnife than it is your other modalities. I mean, radiation being the most expensive, surgery being robotic, which is costly. This is less expensive. Indirect costs are really where we win hands down. And that is, we don't deal with the urinary incontinence. So we don't have pad usage. We know people that are in patients who have urinary incontinence have a higher risk for urinary tract infections. Mostly treated as an outpatient, but as antibiotics, loss of work. Well, that urinary tract infection can lead to a hospital admission. It can lead to sepsis in the ICU. So we're saving those costs. It does have some mortality associated with it. Erectile dysfunction. We know that, we don't have to have drugs and treatments. We don't have the complications of some of the drugs, especially like Trimix and priapism in the ER. We don't have, prosthesis or penile implants having to be put into place. And understand, and not to be understanding, men who have urinary incontinence or men who know, simply the fact of not knowing or knowing the fact that you cannot have an erection affects social epness, social interaction, and actually work productivity. So those two complications of whole gland therapy actually affect us as a society because those men are less productive. And we know that less productive men tend to be more depressed. Depression has a cost. It has medication costs, loss of work. It has cost of suicide. So again, these are things that we are downstream affecting like we never have before with this disease. Again, 1909 first prostatectomy, and we've not had a focal therapy till now. So a couple quick cases. I just want to drive the message home. It's a 54-year-old guy who's an avid hockey player. So I'm 53. I don't know how a 50-year-old plays hockey for 3 nights a week, but he does. He has a PSA of 11, so he knows he needs something treated. He does have a family history of prostate cancer. He's now an empty nester. So him and his wife really were beginning to finally focus. He's very successful sales with a Fortune 500 company of enjoying their life, hiking, hockey. Sexual intimacy was extremely important to them. He had NanoKnife. His current PSA from 11 now is 4.7. He's had a biopsy-proven successful treatment, and he continues to play hockey 3 nights a week, full erectile function, and fully continent. And from somebody who in this sales position has a lot of people across the country, he had seen people have radiation and surgery and all this stuff. And he even he told me, he said, look, I knew I had to find something different. So that's what he just, this is when I chose to drive the message home with several points. And I'm going to focus on this in a second. So 70-year-old gentleman, his PSA is almost 8. He undergoes a biopsy because his MRI has a lesion on the left. He has 3 cores of unfavorable risk prostate cancer, intermediate risk prostate cancer on the left. He has 1 core with grade group 2 favorable. He has 1 core on the left, which is grade group 1. But he also has 1 core on the right. Everybody initially said, this guy's not an NanoKnife candidate. He's not a focal therapy. He's got bilateral disease. Well, as I've said, I don't live in the box. I live a few states over, and I'm like, no way. He underwent bilateral sequential IRE. So he had treated treated left side first. 6 weeks later, he's doing well. We treat the right side. This was done in 2025. Again, remember his PSA was 7.9. He has unfavorable risk, intermediate risk prostate cancer. His PSA January of 2026 was 0.1. This is the PSA you would see after radical prostatectomy. This is a PSA that most likely is lower than most radiation therapies. So what have I said multiple times? His BPH, IPS, AUA score for how he pees was decreased from 13 to 6. So he went from a mild to moderate risk, trouble voiding, stream flow, etc., to a normal flow. This guy depicts the concept that we're outside the box. Number 1, unfavorable, check that box. Number 2, can do both sides in 2 different settings. Can't do it at the same time, but could do it in the same setting. PSA reduction, MRI resolution. This guy has hopefully will end up with a proven biopsy negative. And once he's had that biopsy at 6 months, he now does not have to have MRIs. He does not have to PET scans like the active surveillance guy. So again, just a win, win, win. And I know I'll put just a couple great quotes. I love talking to people. I love knowing what they do. I don't remember names. I love knowing what they do, how they interact with their treatment, their life, and how I can try to make it better. So this is from Wednesday. The 74-year-old gentleman with prostate cancer, grade group 2. He had severe LUTS. His prostate was 74 grams, was actually contemplating a BPH procedure, which led to the finding of his cancer. His quote was, "I pee like I'm 18. And if you've ever seen a man smile like none other, maybe outside the birth of his children or his wife, Mary, Have him go from horrible time peeing to peeing over a fence or across the parking lot, or like he was when 18. You won't see a bigger smile ever on a man. And then finally, grade group 2, 68-year-old treatment. First time I've ever heard this. Now, understand, I've been doing this almost 25 years. I trained at Emory, a very high volume place. So I've taken care of a lot of prostate cancer over my life. This one made me take the box and begin to tear it up. The guy looked at me after his prostate cancer treatment. I think he was about 3 months. And I said, "What do you think?" His direct quote to me, and I'll never forget it, was, "Like the treatment never happened." So of you in medicine, when have you ever had a patient look you in the eye and say, "I had a therapy like it never happened"? Now put that one step forward. How many times have you ever had a chemo patient, a radiation patient, a surgery patient, whatever it may be, tell you that? It'll shock you to the core, change, and make you want to get a lot more people into this treatment disease. Okay, I could do this all day long, but I gotta stop here. So takeaways: focal therapy is a targeted therapy, but it can be regional. Okay. We want to preserve the man. He likes what he does. He's built his entire life getting to the point of this age in his life and his career, his success. He doesn't want to have it ripped from his hands. And that's another great quote. That was from the 54-year-old hockey player. He said, "I just didn't want this ripped from me." And that'll shock you as a provider, as y'all all know, to do better the next day you come to work. Most men are candidates. Limitations are only really perceived. They're mainly due to experience of the technology. And that's a changing paradigm. The people that started doing a partial nephrectomy were literally crucified for doing it. People that took the whole kidney out said, "You're going to hurt people. Their cancer is going to recur." And now what is the standard of care of kidney cancer? It's partial nephrectomy. Know your options, challenge the current thought, and get outside the box. A couple websites for reference. I probably missed a whole bunch of stuff, but that's as good as I can do. I will turn it back over to you for questions, and I hope everybody will ask them, because this is important.
Yeah. That was a great presentation. I tell you, I've been involved in urology for 40 years, and so I've really seen the changes over time of how we treat prostate cancer. And I think Lori could probably attest to this too. Nurses are the ones that deal with all these side effects. Patients come to us with their erectile dysfunction. They come to us with their incontinence and all these other issues that they'll run into. So having other options really, to me, is fantastic, especially first line therapy and high cure rates.
Well, that's the thing, is we're on par. If you look at radical prostatectomy, it's about a 14% recurrence rate at 6 years, especially when you get into those intermediate risk. We're 16% in treatment failure rate with the PRESERVE trial, which is the largest trial out there right now. And I think even some of that data early on, and some of those patients treated early on, were very, focused around a lesion. They didn't get as much margin. Statistically speaking, couples over the age of 70 who maintain sexual intimacy actually live longer. So sometimes we kind of joke and talk about, it's just intimacy, it's just sex, whatever. But these couples physically live longer, and you cannot ignore that. That's what brought into the restoration early on in my career in 2017, when I got an interest, or 2007, when I got an interest in male ED, erectile dysfunction, and restoring it. Is because these people are just happy. They're more productive. They're socially apt. They go to church. They go to their events, their kids' events, etc. So can't overlook that.
Yeah. We do have some questions that came in from the audience, and I'm going to bring those up here. This, I think, is a good one. Susie Swain asks, patient has prostate cancer and BPH. How long after NanoKnife can their BPH be treated?
Okay, I'm going to try to stay on label as best I can. And I get so excited about this one. I'm going to debate and argue and have data to prove they're not going to need the BPH treatment. So I'll give you my first example that drove this message home. He had 181 gram prostate. He needed aquablation. He had a catheter for 2.5 months. So I said, fine, let's do your aquablation. I had to do his workup, his PSA. I couldn't get down, so I had to biopsy him. He ends up with intermediate risk prostate cancer. I did his aquablation. I did one side. He came in 6 weeks later. His PVR was 80 cc's with no catheter. He never had to have the aquablation. Like I said, I've done about 100 cases, and it happened maybe about 3-4 weeks ago. Bless you. The patient looked at me and he had a little bit worsening of his urinary symptoms. And I had to take a double check. I said, really? And I just caught myself, as we sometimes do in medicine with patients tell stuff. So if you have prostate cancer and you have NanoKnife, my suspect is you're most likely not going to need that BPH treatment option. If you do, we can go down that pathway. It doesn't make aquablation harder, any of those. Now, I would argue you'd want to wait about 6 months to prove it. But with the success rates that we have, I think you could probably go ahead and treat it a lot sooner. But my suspect is if you do the aquablation, he may not need that. And I'd want to give it 3 months at least, because my suspect is with the atrophy.
So I think you're saying aquablation, but you mean the NanoKnife.
No, my original patient was to have aquablation. I ended up doing the NanoKnife for his cancer. Okay. He didn't need the second aquablation of his BPH. So if I misspoke, I apologize. Thank you for that.
Yeah, no, I just wanted to clear it up. I think you misplaced the two words. And
sorry. Never happened.
You avoid the aquablation. You may avoid a BPH treatment altogether. Altogether. So I'd wait a minimum of 3 months after NanoKnife before I assess the need for the aquablation. And I would almost argue you should wait, the BPH treatment, I would argue wait 6 months before you defend anything definitive, because my suspect is you won't need it. All right. Lori, I'll let you read this one. It's longer.
All right. Thanks for clearly outlining the non-thermal advantages of NanoKnife, especially tissue preservation and repeatability. From the experience, how do you counsel patients when choosing between focal IRE and thermal ablation for borderline cases?
Again, it comes down to two simple words. My wife says I can take the most complex thing and put it into the most simple things, which sometimes is not the best for home life. But why not? It just comes down to why not. So, again, when I treat with high efficacy, reproducibility without the side effects, I don't have a problem doing it. I've done actually Gleason 8 disease. That's totally off label. The man just absolutely said, listen, I am going to either do nothing or I'm going to do NanoKnife. You can decide what you want to do. And I think that's a bit you cannot deny. He has the right to choose. He's been successfully treated and proven biopsy negative. We in our practice, like I said, our huge experience, almost 200 cases in the past 18 months. So other partners have done that. So what I counsel them is, if this is a modality that you want and I physically can treat you by stacking those triangles that I talked about, then we will do it. We will do the biopsy. And then the biopsy will tell us where we're at. I cannot say that with thermal therapy, because again, with thermal therapy, to get those borderline cases, you're going to have to deliver a lot of energy, which is going to make it harder in the future. And I talked about the ablate and resect. I've actually done that. So I had a patient, he had unfavorable risk prostate cancer, 4+3, chose the NanoKnife, had a very strong family history. He actually was BRCA gene negative. Treated him, and he, at his post biopsy in 6 months, he had all the parameters saying he had treated, but the biopsy still had cancer in it, downgraded to 4.3 or 3.4. And I did his prostatectomy. And I say it took absolutely no longer, no increased complications, didn't affect anything, in my opinion. I would probably say maybe made the surgery 20 minutes longer. I just took a little bit more time in the area I treated, but it was absolutely, I was amazed. So I've actually self-proven this data that comes where they did that 16 times. They ablated, and 16 times they did surgery, radical surgery after it, and there were no difference in increased complications from the surgeries after the NanoKnife.
On the average, how long does a procedure take for NanoKnife?
I like an hour. I've done them as fast as 30 minutes, and some take longer. So again, I've always said that, you cannot hurry a surgery once you actually put the quote knife on the patient. So these are about an hour. Time you're talking about set up, put the probes in, do the treatment, do your checks and balances. That's
the
my
treatment
goal.
Itself takes how long?
No, the surgery, the entire surgery, from time you're going to sleep till you're done, is about an hour procedure. The treatment of the actual ablation is maybe on the 18-20 minute range, depending on how you do it. Mm-hmm. Probe placement, probably somewhere between 5 and 20 minutes. I mean, if I got to place 4 probes around a very tight area in a small prostate, that's not going to take long. If I got to, take a 180 gram prostate and treat an area up here, and then take these probes and put them at the bottom and treat, then it's going to take longer. But that's one of the things that I've willing to take it on the chin. I think it's part of paying it forward. It takes me longer to do the right surgery and lessen your complications. Everything else will work itself out if I just do that. So
now it's done under ultrasound guidance, correct?
absolutely correct. So you are fully asleep. Had to be paralyzed because of electrical energy. You're going to stimulate muscle contraction. So you got to be fully paralyzed, but the ultrasound guides you where you want to place the probes. So you can very discreetly, so you have markers for the rectum, where the urethra is. You have a good idea where the neurovascular bundles are. You can see the capsule, and you just place your needles in a regional area to ablate and eradicate the tumor with the energy.
Now, not all tumors can be seen on ultrasound. Are they
That's
able
correct.
to still use
And that
MRI
is
to kind of like a...
Yeah, I mean, I would say if I get a chance to take a point home, if somebody says you don't need a PSA, a DRE, and an MRI can be absolutely perfect, then please come see me. I will disprove that all day long. So, but that's the disadvantage. Like I said, let's just take cryotherapy. If you don't have a lesion, okay, it's kind of hard to target that. Got to target a regional area, but then you got to let that freeze outward. And when do you turn it off? When do you stop your treatment? With this, I can treat a regional area, so I can treat more area, no side effects, no increased complications, been proven by data. You don't have to have that lesion. And I really like the regional concept. I deal in eighths, quarters, and halves. So you can treat as little as kind of an eighth of a prostate, a quarter, and a half. Most of my people are a quarter to a half. And I have a big question for all the nursing people in the medical community out there. How many halves are in a prostate? Now, most people would say there are two. There's a right and left side, correct?
Correct.
Wrong. Tear the box up, throw it away. There's a top half and a bottom half. There's a right and a left. And that there's a front half and a back half. So people say, we can't do bilateral disease. Well, if you have a right apex and a left apex positive, I can treat that all day long with NanoKnife by treating half your prostate. I'm just going to treat, again, if the prostate's this, I'm just going to treat this half. So once you know the technology and understand its concept and understand that you can treat more than without problems, you now open the door to so many more men that can have this treatment successfully and decrease their quality of life and living with the side effects than you ever thought imagined. Personal story, people told me I was crazy. You're a little ahead of the skis here. Getting a little excited about this. Keep your focus. And to come back and look at being able to treat people with bilateral, unfavorable, intermediate risk prostate cancer, have them have, yes, 2 procedures, no change in erection, no change in incontinence, and curative disease or eradicated disease altogether. If that doesn't get you excited, then you need to kind of question where you're at.
Lori, do you have anybody in your practice doing NanoKnife yet, or?
No, but I do have a couple of questions for you. How do you monitor their PSA afterwards? Because I'm sure that the PSA could be all over the place depending on, how much treatment you give or I was just wondering if you do how do you monitor when they're going to need some more treatments?
Absolutely. That is the big area of my research or interest right now. I'm a clinical applicable researcher. I like to know the practical. So number one, PSA. So the PSA will not go away like it will with a radical prostatectomy radiation. Apologize. Auto lights in the building there. So hopefully you can still see me. Number one, we look for about a 40 to 70% reduction in PSA. Obviously, I've seen more than that because sometimes I'm treating a little bit more area. So I think my PSA is going down a little bit more. Number one, we're going to do that typically around 6 weeks. Reassured patients is dropping down 3 months. So we're going to follow it about every 3 to 6 months for the first year, which is standard for prostate. At 6 months, typically most people do a biopsy. Now, my research interest is if I can get some data and prove that I take an MRI lesion and make it go away, if I can somehow get a PET scan, what's called a PSMA for prostate cancer, and prove that what was there before is now gone, and then I do a biopsy at 6 months and all of those are negative, I think you just simply follow PSAs. You established a new baseline. It's like a guy who has a TERT. He has a PSA of a certain point. He's had that TERT for BPH. You get a new baseline PSA somewhere in the 3, 4, 6 months, and now that's his new baseline. So that's what you monitor his cancer off. So same thing in this situation. We get that new PSA at 6 months, and we look for alterations or changes. It is my hope that getting enough patients that we can do this in, that we can prove a PSA reduction, a change in MRI, and a change in your PET scan will allow you to be followed without a biopsy. We're not there yet. I think we need to test this with the rigors of medical science. And that is, we need to prove, and I think we're actually doing better than some of the other modalities, cryo, radiation. I mean, you have radiation for 50 years now. We've not done the radiation and then biopsy them and proven they're negative. We are doing that. So my older guys, if you're like 75, very active and healthy, then I sometimes will push that out to a year. But I really hope to be able to reduce the amount of burden they have to do. But in a nutshell, it's follow their PSA, follow their MRI and PET scans. You do have to have one biopsy after that. At this stage of the game, I don't think we're going to be there forever. But, and that's a big debate. We don't have a standard protocol of how you follow people after focal therapy in general, but especially with NanoKnife. And I think we need to get there. And I think that's getting some people that, like Mark McClure, or like some of that. You have a guy up in, I'm drawing a blank on his name, in Chicago that's done a lot of these. I'm not sure what practice. Getting those together. Let's test that theory. Let's get that protocol. So people can have the reassurance.
My other question, thank you for that. My other question is, you mentioned that urinary symptoms can markedly improve after this treatment. I'm just wondering why they don't use NanoKnife as a form of a BPH treatment to prevent some of the side effects that other BPH treatments do.
To more information to come. Next podcast.
I'm already there. I'm thinking.
Thinking ahead.
As we say in the South, sometimes, sister, I was there about 12 months ago, but that's okay. I don't want to get myself in trouble. I do just fine. Please, Lord, do not help me. I do just fine.
Completely understand.
Hey, we did get another question. I think that's really interesting here. NanoKnife is a hospital procedure, outpatient, you said. Do patients go home the same day? Well, I guess outpatient answered that. But do they go home without a catheter? That's the bigger thing.
No, they do have. You do have to have a catheter. That is the one crux of this procedure. But again, you have to understand, almost every procedure you have on your prostate is going to have a catheter. So it's not like this is worse. I do a lot of minimally invasive. I do Resume, which is a Boston Scientific product for BPH. Actually, just came out with a protocol that they looked at. We did some data on. They've actually published it to reduce the inflammation, try to control some of those symptoms, and increase the likelihood of the catheter coming out earlier and staying out. Implementing that same thing with NanoKnife, and very rarely do people have to have the catheter go back in, but it does happen. Everybody swells. I use the ankle all the time. When you twist your ankle, all three of us are going to swell at a different rate. I mean, I literally got a bruise playing volleyball on my ankle from rolling it, and no swelling. Now my middle hitter looked at his ankle, and it was swollen for 3 days. So everybody responds a little differently. So yes, you go home with a catheter. It is.
What's
temporary.
your average time that you leave a catheter in?
Right now, I'm leaving it a week, simply because with this procedure, there have been some reports of having some traumatic Foleys, causing some problems after it. I think we need better delineate that, better education. So I tend to err on the side of caution on that. You're getting so much advantage in everything else. Would you give me just a little grace on this one small part? And most men don't, and nobody wants a catheter, right? As a nurse, nobody wants a catheter. However, most people don't mind the catheter once it's there. What do they hate? It going back in while they're awake. So again, use of steroids, these anti-inflammatories, really good. And we're just going to see. Great question, though. Great question.
And he had an antispasmodic.
Absolutely. So part of my protocol is a little bit of the antispasmodics. One of the newer drugs has only been shown to increase your PVR by about 20 cc. So I use that. It's a little expensive. Gabapentin's a great drug. Bringing that back. We used to use that a lot with the prostatitis. That's a great antispasmodic in the pelvic floor. So, we're tweaking that with our protocol, and my partner's kind of helped me adding a little information. So he's done some research on spasms and written some actually AU guidelines on stent and spasms. So we're trying to work together. It's all about, how do we get better? I mean, that's what I'm summing it up is we just have to do better. Because if we're not getting better, we're just failing. We're just, again, if you're not growing, you're dying, right? So I think it's really important. And I really love what you guys do, because you're taking it to the end user. The nurses, I mean, who gets called when Aunt Susie gets an issue?
Yep.
You guys. I mean, I'll never forget in medical school, they told us that the first week, you're going to have a family member you've never called. And sure enough, we all did. I'm like, look, I'm studying biochemistry right now. I have no idea what your treatment of your MS is right now. I mean,
yeah.
So you guys get those. So what you're doing, I really commend that, because I think that not only nurses, but patients, and I've always quoted this statistic, 92% of patients, all comers, will have a urological problem sometime in their lifetime. That could be a simple UTI, right? But a lot of times it's not. Traumatic Foleys are big problems. So knowing how to do urological nursing is key. So thank you for doing that. So
yeah. Well, thanks for that. And I do have a few comments I'm going to share with you quickly. Katie Bortel said, thank you. Absolutely great information and another procedure to think about for patients. Absolutely. Mr. Kumar said, Brent, appreciate the insights shared so far, especially around tissue preservation and quality of life considerations. And Susie said, thanks for your enthusiasm. I think that's contagious. It's so good. This has been a great discussion, and I've been trying to get somebody to come and speak for NanoKnife for a while now, and thankfully I think we got the best. So that's always a pleasure to have somebody who can really break it down, because it's one of the things that having many options is a great thing to have. If the only tool you have in your toolbox is a hammer, well, then everything's treated like a nail. So
I don't know how many. Gosh, you should come live in the South. That's exactly, I'm gonna say that.
I moved to Indiana, so I'm a little south from Chicago now.
I must have said that 4 or 5 times a day. Because again, like I said, if you're not changing, you're not growing. If you're not trying to advance whatever it is you do, whether it's welding, bulldozing, you really have to question: should I get out of bed today? I mean, obviously, everybody gets out of bed of a person because something woke you up that day. We could debate what that is, but something woke you up. So there is some plan for you that day to do. So do it the best of your ability. So knowing options. I mean, I don't know anybody that doesn't want options. I tell people I'm just a stock trader. I just happen to deal with healthcare, because what does a stock guy do? He just options and risk and benefits. That's all. As does this guy in the bed, does he need this catheter bad enough to run the infection, or can I monitor his output by some other way? So absolutely, options are always good.
All right, I'm going to play a quick promo for next week's show.
Join renowned oncologist Eric Jonasz, MD, for an in-depth discussion on optimizing the care of patients with advanced renal cell carcinoma. He focuses on the rapidly evolving landscape of immunotherapy and targeted agents. This expert-led session delivers practical, real-world strategies to help clinicians effectively select and sequence therapies. He highlights how to manage treatment-related side effects while preserving quality of life, and personalize care plans based on the latest evidence. Participants will also gain valuable insights into emerging research and current clinical trials shaping the future of RCC management, offering one AAC contact hour. This essential educational program is ideal for nurses, advanced practice providers, and healthcare professionals dedicated to delivering high-quality oncology care. Join us on January 31st at 9 a.m. Central Time to learn more.
Yeah, that's going to be next week. That's talk about another change is all the different treatments now available for treating advanced cancers. So it's going to be interesting. Plus, you'd be able to get one contact hour for watching. So join us next week. Any last words of wisdom, Lori?
Now, Dr. Sharpe, this has been great because, where I am at currently, we don't do NanoKnife, but it's really interesting. I love learning about things that I'm just not familiar with. So I appreciate it. It's exciting. It's interesting, and I'm going to bring it back to the practice and say, hey, why aren't we doing this? And see what happens.
Exactly. Yeah.
Well, like I said, I would say, again, changing the paradigm. I mean, I just keep saying that over and over in my practice is we're rethinking, we're changing the paradigm of how we treat this disease for the advancement of everybody, both clinicians, the patients, the family, the ramifications will go way downstream. And to your advanced providers out there, I mean, we can't do what we do without you guys. I mean, yeah, I literally would have to go be a welder again if I did not have my nurse practitioner. So y'all get the questions and y'all deal with the side effects more than we do. Y'all are better explaining things. I mean, doctors are just, they're not as good at talking. Y'all are. So please, if you're out there and you're an advanced provider, please go do your homework, because I guarantee you this will touch somebody in your realm soon, if not already.
All right. Well, very good. Well, thanks for coming to our show, and we'll see everybody next week on Euro.